So, good evening, friends. Welcome on behalf of IJH. Our today's speaker is Dr. Hema Parikh, and our topic is efficacy of homeopathy in treating epilepsy. Always been very difficult topic in college days, and when we were seeing the OPDs, the subject actually very less known for the clinicians, right? I remember when I came to ICR, I realized what all steps are there to treat the patient. Before that, I was not knowing anything. So, a little bit about Dr. Hema Parikh. She's homeopath last 35 years. She's MD in repertory. Uh, she is head of the Department of Pediatrics at Srimati Malini Kishore Sangvi Hospital. She is head of Ummid Cerebral Palsy Center, and she is head of Community Health Services. She has presented a lot of scientific papers at state, national, and international levels of homeopathic conferences. She is very regular case presenter at ICR at Vadodara, Pune, Mumbai, and always been very active at Sarla Sonawala Memorial Trust. Uh, she very important contribution in homeopathy is she translated all the aphorisms of Organon in Gujarati and almost all the rubrics of the repertory in Gujarati. That is very important contribution, right? She has received Dr. N.D. Joshi Memorial National Award presented by Homeo Friends at Gorakhpur in 2016. She has also received Emphasis Universal Design Award 2021 for her work in field of disability at New Delhi. Recipient of Homeo Bhushan Award on 9/4/23 by Homeo Friends at Prayagraj. So much is the contribution to homeopathy by Dr. Hema Parikh. So, welcome Dr. Hema Parikh. Enlighten us with your topic of epilepsy.
Thank you. Thank you, Dr. Nilupama. Thanks, and you rightly said a very difficult topic. So, but I have tried to give justice as much as I can. So, is my slide visible, Dr. Nirupama?
Yes, yes.
Yeah. But I can't see others here. Okay.
Just make it full screen. Yeah, it is full screen now.
Full screen, right? Okay.
Yeah.
So, let's start. So, efficacy
Yes.
of homeopathy in treating epilepsy. So, first of all, I must thank my own Homeopathic Journal India Foundation for giving me this opportunity to talk on this topic. So, friends, I'll straight go to the topic without wasting more time. So, my plan of presentation is brief understanding of epilepsy. I don't think I can just cover whole clinically, but what are the important points that I will be trying to cover? Classification of epilepsy, understanding the role of homeopathy through discussion of 3 cases, because we really need to discuss cases to understand that how we can treat epilepsy. We can try to help patients with epilepsy. Just a minute. Yes. Yeah. So, and what is the importance of selection of suitable approach in treatment of epilepsy? Importance of posology, I think it is for us as a homeopath, it is not done if you are selected with the medicine. It's equally important that we observe Canstowell observation and importance of posology. And when we talk about epilepsy, it is still, there's a lot of research going on. So we should try to be evidence-based so far as our cases are concerned. So let's understand what is epilepsy. A neurological disorder characterized by recurrent unprovoked seizure. Seizure, a sudden surge of electrical activity in the brain. Seizure in epilepsy results from excessive electrical discharge in the brain cell. So very important, epilepsy is a chronic disease, non-communicable disease of the brain. And most important for this disease is because we treat so many disorders. So when you talk about epilepsy, it has a significant impact on the quality of life of patient, and I would say, and of family also. Conventional treatment may have side effects and limitation, and so as homeopathy. So it is important to understand what medicines are being given and how what type of medicines and what you cannot taper all those medicine. So if we talk about epilepsy, the prevalence which is there is 50 million worldwide. And if you talk in India, it is 5 to 10 per 1,000 individual suffer from epilepsy. Now, more important. Why more important? Because even today, whatever cases that I'm going to discuss are cases from rural area. And here also it says that rural population suffers more compared to urban population. So that is 1.9 to 0.6 ratio. Now, why of this? Why does rural suffer more? So basically, there are differences in healthcare access. It is said that so many patients of epilepsy are not able to even reach to the hospital. So healthcare access. Another is socio-economic factors. And third is environmental influences. So these are the reason wherein if you talk about urban and rural, the rural population suffers more from epilepsy. And it affects individual of all the ages. But children and older adults are particularly vulnerable. I hope I'm fine. I'm not too fast. I can't see anyone here. So now approach to classification of seizure. So whenever we talk about seizure, how do we diagnose? How do we approach? Of course, neurologist will do it, but when patient comes to you in rural population, facilities may not be there. So there are three important things that we should keep in mind while classifying a seizure. One is where in the brain the seizure starts. So three important is onset, awareness, and movement, right? So in where the seizure is starting. So it's onset. Second is if person is aware or not during the seizure. So awareness is there or no awareness is there. Third is whether the seizure involves movement, right? So these are three important points that we need to keep in mind. Where in the brain the seizure starts, whether patient is aware or not aware during the seizure, and the movement, whether seizure involves the movement, because there is various type of seizure and it is really difficult to diagnose, and that is how it goes very like misdiagnosed and non-diagnosed cases also. So let's go further. So basically seizure is divided into three major groups. Most people will suffer from one or two, and people do suffer from complex seizure, and they may experience number of seizure type. So let us understand 3 points as I talk. Onset. So when you talk about onset of seizure, onset can be focal. So focal onset. We will go in little bit detail about understanding what is focal. Second is generalized onset. Onset of seizure that we are talking. And third is unknown. The onset is unknown. You don't come to know where it starts and how it starts. But this is very important for us to understand that whether it is focal or generalized epilepsy. Now, if you go, I think we know the earlier classification where we have been talking about grand mal epilepsy, petit mal epilepsy and all, but the classification have changed now. And this is International League Against Epilepsy classification. So three major: focal, generalized, and unknown onset. So when you talk about focal, the second point is aware or there is impaired awareness. Right? Third is motor onset or non-motor onset. Focal to bilateral tonic-clonic. It's a little difficult topic, but I'm just trying to make it simple as possible. Then you go to generalized onset. Now, when you talk about generalized, it is motor, which is tonic-clonic or other motor. And there can be non-motor. Same is with unknown onset. Let us go further and understand. So when you talk about focal onset, whether awareness is there or impaired awareness. Motor onset, now motor onset would have so many things in it. So it can be automatism, atonic, clonic, epileptiform spasm, hyperkinetic, myoclonic, and tonic. And non-motor onset, we'll just understand what even this means. So non-motor is autonomic, behavior arrest, cognitive, emotional, sensory. Right? Generalized. That can be any type. Tonic, clonic, clonic, tonic, myoclonic, tonic, clonic, myoclonic, atonic, atonic, and epileptic spasms. And second is non-motor or absent seizure, which is very typical, can be atypical, myoclonic, even eyelid myoclonia. And the third, same motor, tonic, clonic, and epileptic. And non-motor can be behavior arrest, which is again unclassified. So, seizure type we have tried to understand is three important: focal, generalized, and unknown. What is the etiology? I'm not going into detail, but in general, etiology can be structural, genetic, infectious, metabolic, immune, or it can be unknown, which can be idiopathic. Four types, as we have already talked: focal, generalized. There can be combined generalized and focal, and fourth can be unknown. And this leads to epilepsy syndrome. Now, when you talk about epilepsy, there can be comorbidities also. Now, if you see the major comorbidities with epilepsy is mostly, neuropsycho, like psychogenic effect is much more when you talk about epilepsy. So I think this is brief about epilepsy, that how we can approach, so that in clinic also can we understand, at least come to a particular, of course investigations are equally important where you have to go for MRI, EEG, all those things are important, but this what I have talked is important clinically. So focal seizure originate within network limited to one hemisphere. So you can just see it is limited to one hemisphere. And this will also tell us that what type of symptoms patient with focal seizure will suffer from. And then it may discretely localized or more widely distributed. But basically focus is at one particular point in one particular hemisphere. Now what are the motor symptoms when you talk about focal onset? And what are the non-motor symptoms that we talked about? I hope you're with me. So, motor symptoms. So, focal I'm talking about. Now, generalize, everyone know how that behaves. So, focal is part of the body. For example, one arm going stiff, body going limp or floppy, rhythmic jerking in part of your body, particular part of your body, brief and irregular jerks in the part of body, head and eyes turning to one side. Now, any symptom can be there when you talk about lip smacking, repeated swallowing or chewing. These are also symptoms of epilepsy. And that is how it goes unnoticed and undiagnosed, because I've seen so many people. I have someone in my family only that, like, when we are having lunch and she just starts smacking lips. And when you ask, she's not aware and she said, nothing has happened. So again, awareness, non-awareness, and then motor symptom. So jerking movement in one part of your body, usually it can be hand or face, and then it may spread to other part. Having repeated Am I not audible?
Its voice
Someone,
is very clear. Swati, you could check from your side.
okay,
It's clear. It's
clear.
audible. Everyone is it's audible. Yes.
Okay. Only thing I can't see faces. How do I do that?
You make it gallery view then. Then you'll be able
Sorry.
to see gallery view.
Gallery view from up
It's a
here.
speaker view. So make it gallery view. So at least you'll be able to see me.
I
All
know.
other views are.
That's what I really go blank. Where do I get that from? I'm not
See,
getting it.
above that 9 dots,
Yeah,
where there is a speaker view is written.
I don't see speaker view. Hmm.
You see one
Here,
box and then dots, one small box and dot. Right hand side up,
up, yeah. More where it is written, right?
more.
Hide meeting window, breakout, enable, hide. No,
No,
I don't
not
know
that
how
way.
come.
One second.
Oh, yeah,
So in
yeah.
that
Okay, I got
standard
it.
will come. Huh? So
I,
gallery, you do gallery.
I
Side
got
by
it.
side gallery.
Yeah. No, still I can't. Anyway.
No, why?
Hmm,
If you do gallery view, you'll be able to see me, Ketan sir is there.
just a minute. I'll take little bit time. I did gallery view, multi-speaker,
Huh? No, not
multi
multi-speaker.
gallery view I did. So I can now see everyone, but then when the moment I open my slides, I can't.
Then
Anyway,
maybe Priti has made that type of arrangement. I don't know.
no problem. No problem. Fine. Okay. So we were talking about focal onset and motor symptoms. And focal onset where there is non-motor symptom. Now, though this is the list of the symptoms which can be there when you talk about non-motor symptoms. So it can be vision, hearing, smell, hallucination, difficulty processing language. These are the non-motor symptom when you, about related to focal onset. Now we talk about generalized seizure. So here it originates at some point within and rapidly engages bilaterally distributed networks. So it can start from anywhere and then it goes all over. It can also include cortical and subcortical structures, but not necessarily the entire cortex. So this is how this would go. And that is how the symptoms related to this. So what are the symptoms when you talk about generalized epilepsy is there? So focal we did talk about. So when you talk about generalized seizure, it normally follows basic pattern. What? I think no need to talk about it, but muscle stiffens and rigid, violent muscle contraction, muscles moving quick and random spasm, loses awareness, blackouts, right? And then there can be aura before seizure. So we also need to keep in mind aura, ictal and post-ictal phase. So may have odd changes like taste, emotion, vision, smell, hallucination, tingling sensation. The patient may feel disoriented, and that's when patient comes to know that he or she is going to get an attack. So it is very important to even identify what are the symptoms in the aura which can prevent from further injury, and they can be cautious whenever they are outside. Other is during attack. So we all know tongue bite, cheek bite, lock jaw, loses control of bladder and bowel, face turn blue. And then after attacks, postictal, no memory of the event. They may experience drowsiness, headache, confusions, thoughts paralysis. Now, these all are very important for us to understand homeopathically also and to help patient and guide patient what precautions should be taken. I think this is in brief about epilepsy. I have not gone into so much of detail, but broadly we should be able to understand focal, generalized, and awareness, non-awareness, motor and non-motor symptom. So let's go to case number 1. Again, this is from rural area, and this patient was referred by our health worker. She is 17-year-old girl. Her education is still 8th standard. She is a vegetarian, eggs and father and mother. Father is doing farming and mother is housewife. She has one brother who is 6 years old, sister who is one elder who died out of valvular problem, and second younger sister is 13 years old. So let's understand what are her symptoms. So onset is very important. Onset is in focal also, and onset in the form of at what age complaint have started. So here complaint has started at the age of 5 years, and the frequency of convulsion was once per month. So there was seizure, there would tongue bite, pain in head, extremities where there will be body ache and stretching, eyes are dilated, weak memory, especially after episode post-ictal. There is no aura that she does not realize that she's going to get an attack. There is no history of urination, defecation, injury, and there's no loss of consciousness. I would say that when you talk about epilepsy and so many disorder, we should write down negative data also, which is very important. Again, I'm not audible.
When it's clear. Some
Okay. Okay. Yes. What happened? Yeah. So convulsion, now we know what is the age of onset. We know what are the symptoms. We know all the symptoms that we talked about in focal epilepsy and generalized. So I think when we understand that, everyone can diagnose that what is the type of epilepsy that we are treating now. The modality was there that it used to happen at 8 p.m. and 3 p.m. That's the only modality which was available. And patient is under the treatment level 500. And that is since 5 years of age till now, 17 years of age, she is on this medication. Now since 8th standard, so at the age of 13 years, her frequency increased from once in a month to 1 to 2 times per week. And the duration also increased, which was 5 to 6 minutes, which has almost become double, which is 10 to 20 minutes. And this patient comes to us, rather, she is brought to us by our social worker. These are the investigations available. So, of course, EEG is important. Generalized epileptiform abnormality is consistent with diagnosis of primary generalized epilepsy. There are two EEG available, and then we also went for certain EEG. So, like same chart I'm bringing to understand how do we diagnose epilepsy. So, isn't that generalized? Onset is childhood and generalized. There are chances of structural involvement, and the etiology is unknown, because on asking also we did not get any reason why that convulsion started. There was no injury, nothing. And there is no family history also. And that is how we can just consider it is generalized onset. Of course, there is tonic-clonic spasm. So it is generalized motor tonic-clonic spasms are there. And that is how you can just diagnose age of insult, 5 years of age, etiology unknown, so idiopathic, and seizure type is generalized seizure onset. So diagnosis is generalized epilepsy. So let's understand. This is what Dr. Nirupama was talking about, various, tools and forms where we use at ICR, what she said. This is one, I'm not going into detail, but this really helps. This is a tool which is known as structure, form, function, and time. And this allows us to understand what is the pace of the disease, clinical state and stage, and most importantly, miasm, right? So physical characteristic, we take homeopathic case taking, which will include everything. So she's lean, thin, British, partial perspiration on face and neck, craving sour, pungent, ice cream, Chinese food, and she's averse to milk. There is no major issues with sleep except that it is disturbed from noise. Dreams are there but are unremembered. So this is at the level of physical. She has aggravation like headache, which is aggravation on traveling, car headache, sun aggravation headache, and her thermal state is chilly C3H2. Now her mother's obstetric history is important. So you can see how many, she's G7, G8 gravida, and four are of course surviving. I won't go into diet and daily routine, but it is equally important to understand there's family history of cancer. There was no major thing visible on examination. So let's understand her. She's coming from a Rajput community, born and brought up at village, from a joint family. Father is cool and calm, and mother, she's housewife and very irritable if someone does not follow her instructions. Patient was going to school. She continued till 8th standard. She was average in studies, and then her homework always used to be incomplete. And she stopped education because there were no education available in the same village after 8th standard. And because of her complaint, she had to leave education, studies. She was not allowed to go out. She doesn't like to work in any case. She wasn't very keen for going for education. She's also cool and calm. She does get angry if someone scolds. She also weeps if parents scolds her, especially for household work, because she's very slow in work, but definitely she's tidy. She likes neat and clean work. She is pampered child, but restrictions are there because of her chief complaint. She wasn't allowed to go out for marriage or for social function. But overall, there has been no major issues. As I said, we could not find any stressor or anything in her life space. So normally pampered, desires were fulfilled. There was no fights with siblings. Her performance, as I said, was average. And she's very sensitive, but not much ambitious. Like her friends went for studies further to other villages, but she did not. She has a fear of snake and dark, and fear that, there's continuous feeling that mm, I'll get an attack of episode of seizure. She is sensitive to reprimand. She doesn't like to be scolded. She's indolent overall, but tidy and slow. So this is only data that we are able to get. So what approach we will take? Kent's approach was taken uh, because there are qualified mentals. So this is repertorial totality. And this is repertorization. So repertorial result has majorly arsenic, calcarea, natrum, belladonna, china. So three major remedy which comes up group of remedy, because when you go for thermal differentiation as a PDF, potential differential field. So calcarea, sepia, phosphorus came up for differentiation. So I think all are aware which medicine you will give. Anyone can just write in chat box. Remedy seems to be very clear, right? Anyone?
Phosphorus, sepia,
Okay.
all the three calcarea carb, phosphorus,
So how do we
calcarea carb,
differentiate?
calcarea carb.
Yeah,
So more
yeah.
on calcarea carb
So let's
and
go by
few
more.
on phosphorus.
Okay. So then you
Yes.
can again do PDF, which is important. So where you can just take symptoms without which you are not going to prescribe. And again, when you do PDF, where craving, aversion, physical generals were taken, calcarea comes up very prominently. Phosphorus and calcarea, of course. But if you see, there is indolence, there is slowness, she's not very ambitious, sensitive to scolding, does not forces her to work further. And that is how calcarea carb was selected. And of course, with the complaint of epilepsy. We had also taken time modality. So patient was prescribed calcarea carb. Now here, when you talk about epilepsy, follow-ups are very important. So I would like to rather focus on follow-up. So patient, we started with calcarea cup 33 powder weekly. Frequency, as we know how much it was. And patient was on anti-epileptic level 500 since 5 years of age once. Now after calcarea cup, on 18, I have just taken blocks because there are long follow-ups. And of course, when you talk about epilepsy, it's never a short follow-up of 6 months or 1 year. You have to have follow-ups of years that you can just label that you have been able to do something in that case. So here, when the second convulsion came, it was very severe. Here during convulsion, there was tongue bite and bleeding and headache, which was also better, but body ache. So here we thought that let us introduce intercurrent as a tuberculinum 200 1 powder HS followed by calcarea carb, which was continued. Now we can see how tuberculinum have registered. So convulsion wasn't there. Here we are talking about from 12/9 to 1/11. You can just focus on the dates because I have taken blocks. So calcarea cup was continued. Here stiffness of whole body. But now here the attack comes where she became unconscious and it was for longer period. And EEG was done during that period, which showed, I think EEG is here. This again talks about abnormal EEG showing generalized interictal epileptiform discharge, so which is idiopathic generalized epilepsy. So here we raised with the potency calcarea cup 200. After that, there was only one attack in 7 months. Duration, which was 10 to 20 minutes, 2 minutes. And convulsion frequency only once, as I told. And AED was stopped. She was continuously going with neurologist also. And EG report, of course, was not done. But here also there was an attack where 20 minutes she was unconscious. She became conscious after 20 minutes. So here we again thought of tuberculinum and tuberculinum 1M followed by calcarea carb was given. So here you can just see when only calcarea is given the response and when tuberculinum as an intercurrent introduced, we can just understand the response. So here 5 months, there is no attack. She had stopped anti-epileptic since 27. We went on saying that you should continue, but because it was becoming expensive for them, they just stopped. So tuberculinum was continued and here 1M was done. Again, EEG was done where abnormality was there. And in 18/6, all the complaints were zero and there was no attack of epilepsy here for 3 months. EEG was regularly done. So you can just see 0 about convulsion and all. We continued with QB 10M. We had to raise because this we are talking about 3rd year of the treatment. It is not a very short treatment. And gradually, we had to continue tuberculinum regularly along with rise in the potency of calcarea carb. And then later on, there is only one episode in 2.5 years. Patient was continuously under us. There was hardly one jerk on 20. Okay, why tuberculinum? That is what I showed, structure form function, because there is a discharges which is more, which leads to this complaint. I'll come back to the structure form function, which we have concluded with. Here, patient gets married. There was only 1 year, small jerk. It was like jerk. There was no attack and jerk in 1 year, only 15 times that she said this would happen. That's all. And patient is completely out of AED since many year and her EEG became normal, which we got it done on 16 December 2023. So there was continuous abnormal EEG which came to normal. She is out of AED and there is no convulsion attack later on. What was the reason? Moving from 200 to 1M. Yeah. So that's what, these follow-ups are not of weekly follow-ups. Please mind well. These follow-ups are of for months. So it is not so every follow-up we raised with the potency. After 5, 6 months and then we feel there is some indication, you can raise with the potency. So it was not immediately every week that we went on changing. It was after months together where we find some indication and if it is not under control, we would raise And intercurrent, of course, was given every 15 days later on. Here, single dose every 15 days was given, alternate week. It is written. So if I conclude, you could help with homeopathic medicine. It's the follow-up of 2016 till 24. So you really have to keep a lot of patience. Importance of tuberculinum, which was given. And she's pregnant, she's married, and she was taken consultation with neurologist for getting married and going for pregnancy. And I have a testimony, but I think I would like to skip because I would like to focus. But testimony talks that she was spending 1,500 rupees for 15 days medicine, and that is how they could not afford, and gradually they stopped. They had spent so many money and consulted many neurologists, but that did not help, and she's very happy as on now, and there is increase in confidence. So quality of life of patient we could definitely improve. So I'd like to shift to second case, again a girl who is
You want to take one question on this case?
yeah, sure.
Dr. Bindu is asking how many doses of tuberculinum were given and which potency?
We
And
started with 200 and then we shifted to 1M, and recently in 2022 we shifted to 10M. And how many doses, I won't be able to exactly tell you the number. The reason it is so many years of follow-ups. I have all follow-up sheets written properly, but I have taken blocks here because I can't talk, uh, follow-ups of so many years. But started with 200 and then infrequent, and then we went frequent. And I said that every alternate week, 15-day tuberculinum was given.
why tuberculinum?
Yeah, that's what I'm coming to. So tuberculinum normally, when you talk about here, structure, form, function, as I said, because there is a increase in the secretion of epinephrine. So that is, this is how neuronal excitation is there. There is altered neuron potential. Of course, there are spasm, but that does not lead you to psychotic. And that was the reason that tuberculinum was given.
Levipril continued or stopped after neuro opinion?
Levipril stopped since long. I'll tell you since when. Levipril is stopped since 2/1/18. 2nd January 2018. Now it is 2024. She's off Levipril since 2018. So almost 6 years. And in any case, we cannot label any case of epilepsy cured. That's what even book says, that you can just help them, seizure free. They're out of AED and she's living her normal life. She has read that I wasn't allowed to go for marriage. I wasn't allowed to go anywhere. Now I can go alone and I'm able to go. And that is how I said that we definitely improve quality of life of patient. Can I go to second case?
Yes.
Yes. So, but
All
you can
questions
understand.
taken.
Sorry.
All questions we have taken. Now we
Okay.
can go
Now
to
I think
second
I'll
case.
continue with 2 cases and at the end we will talk, because there are a lot
Yes.
of long follow-ups which is important. Select, as I told, in such type of disorder, rather than selection of remedy, posology and follow-ups are important. That's what Dr. Nirupama, you also told me to focus on. And that's how I'm talking about that. So here is a 10th fail girl. Now the reason for failing is we will talk. 18-year-old girl, again from rural area. She came with a complaint of seizure since 1 year. Now her onset is only since 1 year. So how it started? Uh, once in a month, the frequency. And what are the symptoms? She drops the things from the hands, fall down, occasional minor injury on head. And it starts with the flexion of fingers, tonic, clonic, generalized spasm, occasionally frothing from mouth, giddiness during episode. There is no aura, no tongue bite, and no involuntary stool and urine. There is no history of febrile convulsion. Now, since 15 days, why they came to us is that the frequency have increased to once in a week, and that remains for 2 to 5 minutes. And this happens mainly when she wakes up. And she is already on tablet Clove since BD. She was. And then from 28/10/15, she stopped since 1 month because there was a side effect according to her that whenever she takes that, she used to feel drowsy. And that's how she stopped on her own without consultation. Along with that, she since childhood was very fastidious, and since ninth standard, that had increased. Like she would wash hands frequently. Like the mother said that every 10 minutes she would go and wash hands. Now she came with the investigation report. We didn't have EEG when she came, but MRI report was there which says mesial sclerosis of right hippocampus. So we had to study. So her final diagnosis is generalized tonic-clonic epilepsy, mesial right lobe, temporal lobe epilepsy. So there is a sclerotic changes in hippocampus. So these are physical generals: craving chocolate, cold drinks, ice cream, spicy. Patient is ambithermal. There was no other major characteristic, so I will just focus on her life space. Born in Mowad village, Padra Taluka. Parents, two younger brother, grandmother, paternal auntie. Father is farmer and he has studied till 10th, wherein mother is Anganwadi worker and she has studied up to MA. Mother is described as irritable. She is irritable and mother used to get angry whenever she did not complete her work properly. Like, so if you talk about patient and mother relationship, it was strained because she didn't like to be scolded all the time. And she said mother scolds even after completion of work on small matters and for study. Patient feels hurt and bad that I am doing work and she has habit to get angry on me. And patient would reply to mother that I will do all work, you don't nag me continuously. So she didn't like to be nagged and, scolded. She studied at mama's place from 1 to 5th, 6 to 10th at her house. She was getting good grades. Now, when she was in 10th standard, here also we are not getting any stressor. But in 10th standard, she got an epileptic attack and she was admitted in the hospital. And that is how she failed in 10th. And even when she failed because of this complaint and since she was admitted, even mother's reaction as patient said that she was very bad. She said that, what are you doing in school? We had spent money for your study even though you failed in exams. So patient felt very guilty for not able to study well and wanted to study further. She does become anxious about future and she has anticipatory anxiety for study. She feels nervous, trembling of hands. She thinks that everyone will do work in future. What will I do in future? And during this conversation, her eyes were wet. If we are educated, then we can educate others. So she was repenting on that she could not continue with the study. Her nature, she is very irritable, gets angry if someone advises her. She does not like advices. She does not like to be told. She fears being alone. She is fastidious and she was everything neat and clean. She did, like mother said, that when she is mopping the floor, she will not allow anyone to even walk in. There is definitely a feeling of loneliness, as patient said, and she broods on the result and she becomes sad. She's very much depressed as on now. Father was also upset about result, but he encouraged that give examination again. We really tried to explore any event which took place before convulsion, but we could not get. She has two brothers. There is also strained relation. She fights with brothers also. Mother's interview was taken. This was what I talked before was told by patient herself. Mother also said she's very irritable. She wants to do everything according to her wish. She's fastidious, used to be mopping and cleaning utensils after even grandmother does. She's sensitive also, but she does not like to be advised. She does not sensitive to criticism, comments, and advices. Someone told her anything about her work, she cannot tolerate. Would respond, now you do on your own, and she will leave. So she gets angry even if someone teases her. So I think we have many qualified mentals. So approach, of course, was taken Kantian approach with characteristic physical general. So this is her totality: repertorial syndrome, sensitive, anxiety, loneliness, fear, anger, spoken to, advised when. All the symptoms that we have talked has been taken up along with characteristic convulsion waking after. And PDF which was done was nervous with trembling of hands and sun aggravation, headache, and giddiness during menses. So repertorial result comes up is platina. Okay, I didn't think about, but definitely platina comes up. Just a minute. Yeah. So when I repertorize the case, natrum mure came up, calcarea, and when we go for PDF, so these are carcinosin, natrum, calcarea, nux, phosphorus, sulfur, pulsatilla, and sepia came up. So when you go for PDF, again, ambithermal PDF is thermal differentiation is one of the factor. So here, when you talk about PDF and ambithermal, pulsatilla carcinosin can be anywhere and pulsatilla comes up. But looking to her irritable as a core with reactivity not working and getting angry and aggravation, consolation or advices she does not like, natrum mure was selected. Now I would like to focus on the posology. I would not go for differentiation more here. So natrum mure 200 was started. Now the learning here, I've taken 3 cases where there are different learning. We, I would say, have almost 70 cases of epilepsy that are under treatment at our Sumeru hospital. But I've taken 3 different. Now here what happened, we started with natrum mure 200. But we didn't find any result. So as usual, we introduced tuberculinum. Again, we could not find and we found that the complaints were getting worse and worse. So we found partial amelioration, then status quo. Then we thought it is miasmatic block. So we introduced tuberculinum with CR. Still there was no difference, and that is where we did review with the posology, and we decided that considering the temporal lobe epilepsy with the structural changes available at MRI, let us introduce it LM potency because we reviewed and natrum mure remained the same. So you can just see what happened when 200 was given, and then we introduced natrum mure 0/1 3 powder HS weekly. And you can gradually see the improvement which started happening within. This is the case where we could find earliest result because she's off AED. She's not taking any anti-epileptic remedy since the beginning of the treatment. And she's off AED till now. And then when we did EEG on 13, 10, 17, EEG was normal. And to our surprise, MRI, which was done on 19 to 18 because there was no convulsions in so many years, and obsessive symptoms, which we said that she was doing, repeatedly washing hand every 10 minutes. Everything was normal, and her MRI report said that there is no significant diagnostic intracranial abnormality. Just sorry. Yeah. So here, within short period and starting off, but this is evidence-based. And we were also surprised, and I tell you that even MRI was done at the same place where we did before. And this all reports are being seen by our neurologist because we have in our team pediatric neurologist also. So this case was really, we were really happy that patient was off AED, off her complaint, and patient is still, because mother is a ASHA worker, we regularly meet her and she's under observation. Now, very important thing that when patient is normal, we may not stop. We should continue at least certain doses, and they should always be under observation. So this is the second case. Can I go to third case? Dr. Nirupama, we have time. Can I go
Yes,
to third
yes.
case? Yeah.
Yes. We have 10 more minutes.
Yeah. I think then the other
Yeah.
important aspect, this is the girl. So two girls we could help in rural area and we could definitely improve the quality of life. So importance of knowledge is posology, importance of follow-up assessment interpretation, Kent's 12 observation is very important and LM potency. So let's go to third case. So here again a case of a boy. We have dealt with two girls. Now we are coming up with boy. Now this is very interesting case. Like he's 19 years old boy and this is a case of epilepsy with mental retardation. So now here this patient was identified in rural camp and was referred to the hospital. Now since 2 years of age, patient had epilepsy and that started after head injury. So patient had fallen down, everything was okay. And then the epilepsy attack started. Patient's age as on now is 19 years. And the brief screening which was done said that patient had been under treatment of 2 to 3 neurologists till now. Each neurologist treated for 2 to 3 years without any result and AED had been continued. And they further said that we have spent lakhs of rupees without any relief. And they were in really hopeless state. And that is how they came to us. So it is like the birth history, we have to try to analyze that what is the cause, whether head injury have brought this or there is another thing. So neonatal pathological hyperbilirubinemia was there, blood group, but till 2 years of age, all milestones were normal. So that definitely says that everything was normal. And at 2 years of age, patient had fallen down, there was head injury, there was trauma, and that is how the complaint has started. So episodes of seizure, it started less before, like initially it was 1 to 2 per year, but they said that it is progressive and the age increases, frequency increases, and when patient came to us, the frequency was 30 to 35 and gradually 40 to 45 episode per is the state that patient was brought to us with. As far as symptoms are concerned, no specific aura was there. Clonic spasm. A proling starts with blinking and converging, turning to left. Cluster continues. Incontinence of urine. Tongue bite present. Frothing from mouth. A proling of eyes. Now you can see this is a clear picture of epilepsy. Now medication you can see. One we had Livipril, one had Cobal. Here you can see how many medicines. So last medication which patient had been having is all the four. Now whenever you talk with a neurologist, I'll just complete and then come back to that. So these are the medicine patient have been taking. So diagnosis, right occipito-parietal infarct with right focal seizure and secondary generalized tonic-clonic seizure in cluster. In 2015, there was status epilepticus, and that was 4 to 5 hours that patient was unconscious. Then there was no convulsion. So they stopped with the treatment. And then again, same episode started with the same frequency. Again, they started with allopathic treatment, same this medication. So when patient came to us, patient is under all these four medicines. And as I told you, so the common comorbidity can be MR, depression. So here patient is, his IQ is 45. He is he's diagnosed case of intellectual disability. Now we don't use mental retardation. Sorry for that. Not able to read and write at 19 years. Communication is poor, difficulty, and ADL is dependent. So all the activity of daily living, he can't do anything. And there was a behavioral thing which was violent, throwing things, beats, anger, and which was aggravated when contradicted. So at the age of 2 years, fall down, if you just keep it in stages, episode of unconscious wave 2 to 3 hours, generalized tonic-clonic, frequency as on now 40 to 45 per day since 5 years, aura not specific, ictal phase, starts from left side, blinking. I think we have seen all those symptoms. And post-ictal, loss of consciousness for 2 to 3 hours. Patient would be unconscious for 2 to 3 hours. So I think these are the medication, as I told you, 4 medicines are given. Now that's the point which is important, that now neurologist said that this is what we can do. Our neurologist also had a lecture and she said, we have only 4. If we reach 4, we do not have anything. They have to deal with it. So they said no more treatment available to control his seizures. This we have already talked about. Intellectual disability. This is the family history. And MRI does say gliotic changes is noted, evolving right parenchymal lobule sequelae to remote insult, prominence of cerebral folia suggestive of cerebellar atrophy. So this is all investigation. Thank you, Praveen sir. Chocolate बनता है बाद में. Sorry. Yeah. So, and this is the diagnosis: left focal and secondary generalized tonic-clonic seizure in cluster with torch paralysis with intellectual disability. Let us understand him. We had a reason. I think everyone must be ready with the prescription. Still, I wanted to understand this child. So he's a very emotional, sentimental, gathers children and plays with them, shares expensive toys. He, of course, likes cleanliness, very fastidious, arranges cupboard. Gradually, he started doing his work, cleans hands, but very aggressive, anger, breaks and throws thing, contradiction, aggravation, likes company, and he's obstinate. He's very, like when sister is married and when sister is going to go home, he would cry, he would miss. He's very sentimental and attached to father, mother, sister, cares and worries about them. Affectionate, these are the other, craving and aversion, and perspiration profuse on skull. And of course, ailments from head injury. Can anyone tell me remedy? Do we need a whole case to be taken or we have a remedy with us? Yes? Cicuta, very good. Cicuta. Anything else? Tarantula. Okay. Okay. So let's see what we did and let us go for follow-up and then we will discuss because we don't have. Yes, Dr. Vidya. So it is net. So here we had taken non-repertorial approach. Now it is again important what approach are we taking. So we have convulsion, which is ailments from head injury, anger, contradiction. These are the symptoms, but we went for non-repertorial approach, looking to the cause. I think everyone is coming up with natrum self and of course head injury, so cicuta and all will come. But still considering the natrum as a core in the patient who is very sentimental and aggressive, we started with natrum self 200, 1 powder weekly. Yeah. So again, coming to the follow-up, what I wanted to focus in this case, that only I will focus because we don't have so much of time. But I tell you, this is how the follow-up goes. So 9 months follow-up, March 15 to December 15. Ictal phase stopped, incontinence, better to gradually reduced and the frequency of convulsion twice in a day. Post-ictal, 30 minutes, which used to be 2 hours. Stop beating and throwing. So violence have reduced, obstinacy have reduced, drooling have reduced. AED, we have not touched, anti-epileptic drug, we can't touch, but understanding have improved. So we continued with natrum self 201 powder weekly. Now here after again 9 months. Now here we are getting something which really needs attention. So here Jan 16 to Jan 17. Mind well, these are follow-ups of years and it's not of days and weeks. So now gradually you can see how improvement has taken place. 3 to 4 convulsion per 15 to 20 days, which was 30 to 35 per day. And the duration of post-ictal unconsciousness became 5 minutes. Violence reduced to a great extent. And obstinacy is only when guests are there. Drooling is not there. And here 3 AED is given. Now why 3? I'll come to that for this follow. That here what happened? Recurrent nausea and vomiting was there, and we went on giving, arsenic and nux vomica, acute remedy. We gave allopathic, also our pediatrician treated. But that wasn't going, and he used to vomit and weight loss. And then we consulted gastroenterologist, opinion taken, and he prescribed symptomatic and suggested there is hepatomegaly. He was admitted in the hospital. Then we consulted neurologist and physician's opinion was taken, and that was diagnosed that drug-induced hepatitis, and that was because of clonazepam. So physician advised to stop abo tablet. And after allopathic plus homeopathic treatment, and this is what is important when you are treating such type of cases, interdisciplinary approach, because we guided for that helped us for clinical state. And most important that one AED was withdrawn. That was by neurologist because we will not touch and we are not supposed to touch. But still, there was no effect in the frequency and that patient went on improving. Now, February 17 to February 18, now you can see the frequency of convulsion is once in 1 to 2 months. And everything is better 3. And here neurologists reduce the dose of other medicine. The 3 medicines out of 4, and the 1 medicine which was 2 was made 1. And overall patient went on improving. In between, there is no episode for 4 to 6 months, except once in 1 to 2 months, and all the complaints are better. So a patient is almost, I don't say he's out, but patients 30 to 35 say as on now, 3-4 months pe ek attack aata hai. That is what we have achieved. So that's how I said you can never label it as a cure, but we have definitely helped patient to recover at the level of mind and at the level of body both. Patient has become independent now. Before, out of aggression, 2 to 3 people were required when they had to bring to the hospital. Now he and his father comes on motorbike. So that is the difference at the level of mind and body. So I think I would like to conclude that importance of case taking, importance of selection of right approach in cases of epilepsy, importance of need of interdisciplinary because we have no right to withdraw or stop medication, identifying drug effects, and role of homeopathy in improving quality of life of patient. So I would say homeopathy aims to stimulate the body's self-healing mechanism, and the individualized approach is a key aspect of homeopathic treatment. But still, evidence on homeopathy for epilepsy, I would say a lot of research has to be done on homeopathic treatment because it is limited and inconclusive. And some studies suggest that there is a potential benefit, and we have also experienced out of 70, and we are also doing research in that. But clinical trials are needed to establish efficacy and safety. So while homeopathy may offer potential benefit for some individuals with epilepsy, it's essential to approach it with caution and in conjunction with conventional medical care. Further research for all of us and collaboration between homeopathic and conventional practitioners are needed. So thank you, Dr. Nirupama. I would like to end my talk with remembering our beloved ma'am, Vishpala ma'am. And thank you. Thank you. I would like to end.
There are 2 questions. You want
Yes.
to take 2 questions? So there is
10. Okay.
only 2 questions are there. In second case, why again tuberculosis? There is 1 question.
Yeah. Shall I complete that? So there we had considered that there is a recurrent gastric infection which is continuously coming. And considering even drug reaction, drug-induced hepatitis, and we had considered natrum sulf not as a intercurrent or something, we had considered natrum sulf as a depacting remedy. And that is how we had introduced tuberculinum here. And then we could see the improvement. So I would say we are working on it, tuberculinum and epilepsy, role of tuberculinum.
Yes. And in third case, homeopathic and allopathic was going on together.
Yeah. Okay, now can I see people so I can, Yes, definitely. That's what I would like to tell, that we can see. Neurologist also said that for medication ये इससे हम कुछ नहीं कर सकते हैं. with that four
It's
medication,
very
how
good.
do we understand? With that four medication, which is that which done with them, still we could, 30 to 35 attacks were there with mental depression and mood disorder. With our medication, it's hardly any attack 3-4 months once. So we did not touch, and we are not supposed to touch any. Even it was made three, and one dose was reduced, was done by neurologist. We have in our team pediatric neurologist. We don't interfere with medication, and we are not supposed to, according to my knowledge.
Yes. And
And there is
what is the
harm
role
in
of
giving.
homeopathy in glio?
Sorry.
What is the role of homeopathy in glioblastoma?
I don't have any experience of that. We have treated
Okay.
gliosis to a great extent in cases of cerebral palsy. Glioblastoma, I don't have any experience.
People are very happy with today's presentation and they are all asking whether recording will be given. So yes, recording will come on YouTube. Soon we'll share with you all.
Okay, thank
So
you.
thank you, Dr. Hema, for a wonderful presentation. And people are very happy that you have given very long follow-up and how to do overall therapeutic planning and programming. So thank you, Dr. Hema, and thank you all our viewers for your attendance and for your timely question answers. So thank you. So our next
Thank,
webinar will be in next month, third Friday, 9 to 10. Thank you.
thank you. Thank you very much. And certain answers I could not, we can check. My mail ID is there in our group. Thank you. Thank you,
Yes.
Dr.
Thank you.